So this MEC minute is the July version, and our discussion today is going to be wide complex tachycardia. This is a topic that for us may seem simple in terms of our protocol, but for me as someone who's developing the slide deck and making the presentation, it's one of the harder talks that I've had to put together over the past 10 years. So bear with me. I want to talk about wide complex tachycardia, talk about the treatment, but I also want to give some background in terms of what's happening with wide complex tachycardia, the alternate diagnoses, the alternate presentations or rhythms, and give you some feel for the things that I think about behind the scenes when we talk about this, particularly when we talk about wide complex tachycardia, and it could be something other than ventricular tachycardia. So what are we going to talk about today? We're going to talk about wide complex tachycardia, a bit of a definition, and some about etiology. We're going to also talk, though, about SVT or supraventricular tachycardia with aberrancy, where you have SVT with wide complexes, and is this SVT with aberrancy, or is it truly ventricular tachycardia? Talk about how do we tell the difference. Talk about treatment options for wide complex tachycardia, and some of this I'm going to take a little outside of what's in our protocol, just so that you have some background thoughts and ideas. And then I got some call outs at the end that I want you to be aware of. Principally, I'm talking about accelerated idioventricular rhythm and Wolff-Parkinson-White syndrome. So let's get started. So here, let's start with a case, and this is a real case. We have a 91-year-old female. She feels weak with palpitations. She has a history of coronary artery disease. Her blood pressure is 100/70. She's alert. She has normal respirations. The crew did a rhythm strip, and you see that on the right. And I want to point out that you can see something that looks like a P wave here. So what is our interpretation? Well, this is wide complex. If you look at the QRS duration, it's more than 0.12. So it's some type of wide complex tachycardia. It looks regular. It looks like the rate by my calculations is around 170 beats per minute. So it's a bit fast, particularly for a 91-year-old. So the question is this supraventricular with aberrancy? Is it ventricular tachycardia, and how are we going to treat it? So when I look at it, I see those waveforms look like T or P waves, so it could be atrial flutter, it could be P waves from an SVT. Not really sure at this point, but how am I going to treat it? What are my treatment options? Well, for us, the question is going to really come down to stable versus unstable, but then also other considerations. Should we treat this? Could this be atrial flutter when we give the patient cardizem, or is this ventricular tachycardia that we're going to treat with amiodarone based on our protocol? So something to think about. So definition and causes of ventricular tachycardia. So it's really any rhythm over 100 beats per minute with a QRS duration over 12 milliseconds, or three small boxes on the rhythm strip or on the 12 lead. So by definition, any heart rate over 100 is a tachycardia, and if it's if QRS is greater than 12, then it's wide complex. What could it be? Well, we always think about ventricular tachycardia, but we also think about things like SVT with aberrancy, including atrial fibrillation and atrial flutter. It could be SVT with a metabolic disturbance, such as hyperkalemia or tricyclic antidepressant overdose. It could be WPW with tachycardia and associated aberrancy. It could also be something called accelerated idioventricular rhythm, which we'll talk about halfway through this discussion. So for us, though, the problem is not all ventricular tachycardia looks like this. For us, this looks pretty obvious. It's VT. We're going to treat whether they're stable or unstable, and they'll either get shocked or they'll get amiodarone. So what other things could we think about that might help us make a decision about, is this VT or not? Well, in a clinical setting, certain things would suggest that this is ventricular tachycardia and not SVT, particularly if the patient's over age 35. So if it's a 20-year-old who's got tachycardia and wide complex, it's probably SVT with aberrancy. But if they're over 35, it's more likely that the patient has ventricular tachycardia. It's particularly suggestive of VT if the patient has known structural heart disease, like aortic valve disease or mitral valve disease, or they've had a valve replacement surgery, or if they have a history of MI and ischemic heart disease, or if they have a history of CHF. It's also, if you look at the rhythm strip and you see that there seems to be AV nodal dissociation, and I'll give you an example, that the patient is more likely in ventricular tachycardia. And when I say that, I basically mean you can see P waves or flutter waves that are regular, and their association with QRS is, or there is no association between them and the QRS. Um, or if the patient has a past history of first-degree heart block, honestly, we probably don't know if they have a history of first-degree heart block unless you have tracings from previous encounters you can review. And be especially careful for patients who have a family history of sudden cardiac death. So there are known congenital cardiac conduction abnormalities that can predispose to sudden cardiac death. If you have a parent or a sibling who's died sudden cardiac death unexpectedly, particularly if the autopsy is negative, then they may have some congenital rhythm abnormality that predisposes to VT. How about for, could this be SVT with aberrancy? Well, the first thing is you have a patient with a known bundle branch block. So they have a previous ECG and you can look at it, or the patient has one in their pocket, or maybe there's one in the physician's office where you're picking the patient up. So if they have a known bundle branch block. The problem is for us in the field, we don't know if they have a previous bundle branch or not, block or not. I would suggest that you not make that presumption. The presumption is this is VT until proven otherwise. You need that old ECG for comparison. If the patient also has a history of previous electrocardiogram with Wolff-Parkinson-White, or they have a history of Wolff-Parkinson-White, you can then pretty much say this could be aberrancy. If they have anything to suggest Wolff-Parkinson-White, we can talk about that in a moment, but avoid the calcium channel blockers. Patient, if they have a history of SVT and they now have another episode, seems like, well, it's more likely to think they have SVT with aberrancy. And another thing to think about, if the patient has history of chronic atrial fibrillation and now they're tachycardic, maybe they have aberrant conduction, or they may have rate-dependent aberrancy, where if their heart rate is normal, they have a normal QRS. If the heart rate's 160, their QRS is prolonged. I kind of think of this as a positive Eliquis sign. It seems like half my older patients are currently on Eliquis, and most of them are on Eliquis because they have chronic atrial fibrillation. All right. So there's other things that you can use to identify SVT. I'm sorry, ventricular tachycardia, not SVT. And one has to do with concordance. So if you do a 12 lead, and if you look at leads V1 through V6, if they have either positive or negative concordance, it's more likely VT. Well, what's concordance? Well, that means if the QRS is going predominantly the same direction in all 6 leads, that's considered concordance. So if all of the QRSs are upward instead of upwards and downwards, that's positive concordance. Or if all the QRSs are going downwards, as if what you're looking at in the bottom right here, on that 12 lead, if you see that, those patients have a negative concordance. So if the patient has any evidence of positive or negative concordance, it's probably ventricular tachycardia. So if in doubt, run a quick 12 lead, look at V1 through V6. If all the QRSs are going up or all the QRSs are going down, it's probably VT, treated as VT. The other thing to think that you can look at is AV dissociation. I've got little circles down there around the arrow marks, and you see that there are little waves in there. They could be a P wave, they could be a flutter wave. For us, in terms of this conversation, it doesn't matter. You see something there, and it does not seem to be linked with the QRS. So it's not like you see one of those bumps and there's a QRS. They seem to be running at their own different rate and rhythm. So if you have evidence of AV dissociation, it is ventricular tachycardia, and you should treat it. So again, it doesn't matter if it's P waves or atrial flutter waves. If you see this dissociation, treat them as ventricular tachycardia based on the protocol. So what is the likelihood that it's VT? And this is something you should keep in mind. So if you look at all comers with wide complex QRS, there's at least 80% probability that it's due to ventricular tachycardia. So if you do nothing but just play the odds are that if you see a wide complex tachycardia, there's at least an 80% chance it's ventricular tachycardia. And if you treat it as such, you've done well for the patient. If the patient has a history of coronary artery disease, there's at least a 90% probability that wide complex tachycardia is due to ventricular tachycardia. So bottom line is if you treat all wide complex tachycardia as ventricular tachycardia, you will be correct at least 80% of the time. I don't know about you, but in medicine, those are pretty good odds. And for most of us, we treat patients based on worst case scenario. So if the worst case scenario, the patient has VT, treat him as ventricular tachycardia. So the bottom line again, wide and regular ventricular tachycardia, treat him as such. How about wide and irregular? So you have a wide complex tachycardia, but it seems to be irregular and it's fast. Well, the things to think about are atrial fibrillation plus Wolff-Parkinson-White, in which case these patients tend to have a very rapid, irregular heart rate with variable QRS complexes, meaning the QRS can change beat to beat. Even though it's wide, it's not the same size or direction. The amplitudes may be different. Hyperkalemia is something we always think about in any wide complex rhythm. We have patients who come in with hyperkalemia and their 12-lead ECG is bizarre. And you look at it, you don't know what it is. You give the patient some calcium or some calcium and bicarb, and things improve. We also think about sodium channel blockers like tricyclic antidepressants and antihistamines. Those medications can cause wide complex tachycardia. If you look at our treatment protocol for overdoses, we actually have a arm on the algorithm for tricyclic antidepressants. They have similar manifestations as an antihistamine overdose, like Benadryl overdose. We treat those patients differently. We treat them with fluids and bicarb. And then the other thing we have is accelerated idioventricular rhythm, which I'll talk about. This tends to be a reperfusion arrhythmia associated with coronary artery disease and acute MI. We used to see a lot of this when we used to give IV thrombolytics because we didn't have stenting and cardiac cath immediately available. All right, so how do we treat it? Well, here's right about our protocol. Our protocol looks pretty straightforward. We have patients who are stable or unstable. And if the patient has no palpable pulse, we're going to treat them as a VF arrest. If the patient has a pulse but is unstable, we have one arm. If the patient has a pulse and is stable, we have a different arm. So what do those arms look like? Well, if the patient's unstable, we can treat them for unstable VT, and our treatment is pretty straightforward. We sedate and we shock. And then after the patient's back in sinus or some type of perfusing beat, we give them a dose of amiodarone. So for us, any unstable VT gets cardioverted. And honestly, it makes it simple for us if we think about it as any patient with tachycardia that's unstable and we think their tachycardia is due to a cardiac etiology, we will cardiovert. If the patient's 140, 150 because they're bleeding out, we don't cardiovert. But most of our patients in this world are not having any cause of acute blood loss or volume loss. We don't need to, we can think about just converting or cardioverting those patients who have an unstable arrhythmia. How about the stable? So if you look at it, our algorithm is pretty simple. We do a 12-lead, and we're going to give amiodarone at 150 milligrams over 10 minutes, and it's pretty straightforward. But I'd like to really give you some background about medications and how we might think about treating these patients in the emergency department. So really, I need to go back a little bit, talk some about American Heart Association's ACLS guidelines. And I think to start, I just want you to kind of give you a quick reminder about what they call levels of evidence in terms of what they use to support their recommendations for treatment, and it's based on the amount of research and professional opinion that backs the recommendations. So this is out of their book, out of the 2020 guidelines, and if you look at it with some magnification, these are kind of level of evidence, and the best is class 1, which means the recommendation is highly recommended. It's been shown and proven to be beneficial to the patient, and the benefit greatly exceeds any potential risks. But if you're looking at the recommendations from American Heart that has to do with medications for ventricular fibrillation, ventricular tachycardia, most of them have what we call Class B evidence, which means the benefit seems to be better than the risk, but it's not the strongest. It's kind of a middle of the road recommendation. So the level of evidence for the recommendations for ventricular tachycardia and wide complex ventricular tachycardia are not the strongest. And here are their recommendations. And again, if you look at their recommendations, and this has to do with medications for wide complex tachycardia, their 2B recommendations, which, like I said, don't have the best level of support. But I think it's worth looking at these recommendations. So what they recommend is that in hemodynamically stable patients with wide complex tachycardia, you can consider giving IV adenosine to aid in rhythm diagnosis. Now, we used to have adenosine in our protocol as one of the steps for wide complex tachycardia. We took it out because it didn't seem to ever work, and it just seemed to distract our providers from other priorities. And again, if you think about our patient population, where at least 80% of our patients with wide complex tachycardia are going to be in VTAC, and the older patients with significant risk factors will have a 90% chance or better of being in VTAC, do we really want to spend time giving the patient adenosine? So that's okay. We've kind of been there, done that. We had it, we took it back out. It didn't seem to be effective. The other recommendation is they recommend IV amiodarone, procainamide, or sotalol for the treatment of wide complex tachycardia. Amiodarone's in our protocol. Procainamide is an old world medicine that was around when I was a medical student. It was very heavily utilized in the 80s and 90s, but with amiodarone and other antiarrhythmic medications coming out, kind of found by the wayside. However, if you look at the literature, procainamide is still drug of choice for some arrhythmias, particularly things like irregular wide complex arrhythmias or WPW. Sotalol is a beta blocker that is good for treating wide complex tachycardias. It tends to be an oral medication. It's not something in our toolbox. The other one I would really like to put out there is that verapamil, which is a calcium channel blocker, should not be administered for any wide complex tachycardia unless we know it's to be supraventricular in origin. So for us, verapamil we don't use, but we use cardizem. Cardizem is also a calcium channel blocker. And so the recommendations from the American Heart Association the recommendation is that we not use cardizem in any patient with wide complex tachycardia unless we know it's supraventricular in origin. I think it'd be very difficult to expect all of our providers to be able to distinguish or make a determination that the patient's tachycardia is due to atrial fibrillation or SVT unless we give the adenosine challenge. But for us, I don't think we should try to give or consider giving cardizem to a patient who's got wide complex tachycardia. And then the last thing on the recommendation is we not give adenosine for hemodynamically unstable, irregular, or polymorphic wide complex tachycardias. That's because it may make some things worse. It may be ineffective or probably be ineffective, and it just delays time. If the patient's hemodynamically unstable, cardiovert them. Okay, back to our protocol. So again, we're going to put a stable patient, we're going to put them on a cardiac monitor, we're going to transmit a 12 lead, and then we're going to give them amiodarone as an infusion. If at any point the patient becomes unsteady or unstable, we're going to sedate them, we're going to cardiovert. So how about a couple other things? So let's talk about accelerated idioventricular. This is one that I talked about, and again, we used to see this mostly as a reperfusion arrhythmia. You get wide complex rhythm, but it's not really that fast, and really it's just patients got idioventricular rhythm. The ventricles are determining the heart rate. Typically, it's in the 60 to 100 range. We do not treat these. So the treatment for these really is supportive care. We do not give amiodarone or lidocaine for AIVR because it may cause cardiovascular collapse. What we're looking at is we are seeing ventricular rhythm, and if we give a medication that's going to abort that ventricular rhythm, the patient may have no rhythm, so they go asystolic, their cardiovascular system collapses, and they die. So we don't see these as often as we used to, but I'm suggesting that if you see a patient with a wide complex arrhythmia or a wide complex rhythm, and it's between 60 to 100, I would just leave it alone, provide supportive care, so maybe some oxygen, see if they have any risk factors for cardiac disease, see if you need to treat them for chest pain or something else, but do not treat the rhythm with amio. Wolff-Parkinson-White syndrome, I've said in the past, this is sometimes my worst nightmare. And the reason I say that is because it's out there. I think I've seen 2 or 3 cases over my 40-year experience, but these patients can be tricky. Wolff-Parkinson-White is due to a accessory pathway that can result in tachycardia. And if you have a patient with Wolff-Parkinson-White who develops acute atrial fibrillation, they can get an irregular tachycardia. And on the top right, I've got a patient who presents with this rhythm, and on the bottom right is his 12 lead after conversion. So if you look at the top right 12 lead, it's tachycardic. If you look at any one of the leads, you'll see that you may have some variation in the height of the QRS complex. So they have a changing QRS morphology. Wolff-Parkinson-White patients tend to run really fast. Their rates can be well over 200. The last one I'm aware of, one of my partners treated, patient came in with a pulse rate of 250. He was young, he was sedated, he was cardioverted. And it was after they cardioverted, they saw that he had WPW. If you want to treat these patients, really the drug of choice for WPW and tachycardia is procainamide. I can tell you that I have partners in my group who've been out of residency within the past 5 to 10 years. They know procainamide exists, but they have no experience administering it. They tend to go with amio. There's some discussion that whether or not amiodarone is the wrong drug for WPW, but there's also evidence out there that it is safe. I have used it in a couple patients with WPW and have not had any problems. So if you have a patient with possible WPW, your options are to treat or not treat with amiodarone. It might be better for the patient to just transport. If the patient has the least look or appearance of instability, sedate, and cardiovert. So if you look at the EKGs on the right, the top right is the patient with their AFib with WPW. This is not a bundle branch, or this is not a ventricular tachycardia. It's a wide complex QRS as a consequence of the tachycardia. Once the patient's back in sinus, you can look at it, and he's down the bottom right. And I brought up a different EKG because if you talk about patients with WPW, they have these delta waves where it's a very short PR interval, and that upslope there is considered a delta wave. So if you have a patient with a 12 lead looks like this, they may have some T-wave inversion as a component of their conduction defect. It's not ischemia. It's an evidence of the conduction defect. These patients have WPW. It's something to keep in the back of your head. Most of these patients do fine during transport if you don't find them in tachycardia on your arrival. So how do we treat causes of wide and irregular tachycardia? So for atrial fibrillation, for us, for the protocol, I am comfortable using amiodarone. For atrial fibrillation and WPW, again, I'm comfortable with using amiodarone, although the preferred drug in the emergency department is procainamide. If you have a patient who's hyperkalemic with some wide, bizarre-looking QRS waves, our treatment for hyperkalemia is calcium and sodium bicarbonate. That's why we have it in our cardiac arrest protocol for dialysis patients. Those patients tend to be hyperkalemic. We treat hyperkalemia with calcium and sodium bicarbonate. If we're talking about a sodium channel blocker like tricyclic antidepressants or Benadryl, we use fluids and sodium bicarbonate. And if you have a patient who has taken an overdose, and you are on scene and you identify it's a tricyclic antidepressant or an antihistamine, and they have a wide complex tachycardia, our treatment sodium bicarbonate. Again, that is in our protocol for under overdoses. And then if you have that accelerated idioventricular rhythm I talked about, which is something that's really a reperfusion arrhythmia, we just provide oxygen therapy and any supportive care they need. In summary, if you have any type of unstable tachycardia, narrow or wide QRS cardiovert, if you have a wide complex tachycardia and no palpable pulse, that's patients considered to be in arrest. You treat them the same way as a VF arrest. If you have a stable wide complex tachycardia, there's an 80% chance or better it's VT. And again, if you're talking about the elderly or anybody with a history of coronary disease or heart failure, a better than 90% chance of it being VT. Treat with amiodarone. Procaine is better for some cases, but we don't carry it. So I would treat patients with amiodarone. If you suspect SVT, you can to try the adenosine. But I would not give adenosine to anybody with an irregular wide complex tachycardia. And then do not give cardizem to any wide complex arrhythmia. Cardizem could just aggravate the rhythm, and patient could end up going into cardiac arrest, and you may not be able to salvage them back. So that's it. That's the end of the conversation. Hopefully I haven't confused you too much. My hope was to clarify things and to also give you some additional background on how we identify, treat, and manage patients with wide complex tachycardia. If you have any questions, please post them on Basecamp. Thank you.